Just a couple of little topics remaining, so this will go very quickly. First, fibromyalgia and neuropathy. I kind of talked about this really quickly during pain, but I figured it's neuro and pain, so let's talk about it again. So fibromyalgia, widespread musculoskeletal pain, unknown etiology, cognitive component potentially, diabetic neuropathy, pins and needles sensation mostly in the extremities, postherpetic neuralgia, viral particles moving to the periphery, they cause long-term nerve damage. So those are all the things that are most commonly going to cause neuropathic pain. However, it's all treated the same way. So from a treatment perspective, we don't really care all that much. A couple of these things we haven't covered, some of them we have. It's pretty much, again, going to be the same treatment for any type of neuropathic pain. Antidepressants, which we haven't covered yet, there's a couple classes, tricyclic and SNRIs. SNRIs are serotonin norepinephrine reuptake inhibitors, and those are going to be probably the most common ones. You've probably seen, well, duloxetine's generic now, but they used to advertise Cymbalta all the time for pain syndromes. It was a really common promotion of it. It's an antidepressant by trade, and it's an effective antidepressant, but it's got a ton of use. It was one of the most popular drugs in the United States for a long time because it had such an impact on the pain treatment process and how many studies. So they've not only studied Cymbalta in neuropathic pain, but also like osteoarthritis and things like that, believe it or not. It's been shown to be effective. So anyway, why those mechanisms work, I don't know. We'll talk about it more when we talk about psychs. I'm not going to get into it, but yeah, that's all I've got for now. Anti-epileptic drugs, we already talked about pregabalin and gabapentin. Valproic acid's also common use. I should have put carbamazepine on here too, and maybe be another one to consider. Other options, just like any pain treatment, avoid your opioids as long as possible. And if you do need to use an opioid, try and use them very short term and acute if you have to get away with it. And some of the problems with some of these medications, they might take some time to get to an appropriate dose and to get to the appropriate effects. So you might need to do something in the meantime. Is an opioid appropriate? I don't know, but maybe like an NSAID you could try. I guess that's not going to have a lot of effect on neuropathic pain, but I think I could be wrong, but it'd be rare that you would consider a patient in so much neuropathic pain that you need opioids, but maybe a postherpetic neuralgia, possibly you might see cases like that. Muscle relaxants, things like cyclobenzaprine can be used for fibromyalgia and have been studied in small groups of people. IV ketamine. So if you work inpatient, especially with pain, you wouldn't give this in a clinic, but ketamine could be used for somebody who is in a lot of pain. You don't want to avoid opioids, or opioids might just not be working. I've had a lot of people come into the emergency department with different types of pain where we've pushed opioids, nothing happens, and you try a little bit of ketamine and it actually works decently. Topical, so don't forget about your topicals. Lidocaine gels, ointments, and patches are very effective for all types of neuropathic pain, so especially postherpetic neuralgia is kind of what you'd think about, but certainly for other neuropathic pains it could be helpful as well. Topical capsaicin, which is the ingredient in hot peppers. Did we talk about that during pain a little bit? Okay, yeah, so that would be another one too. So these are all options. I would say, again, everything's kind of fair game in my opinion, with the exception of opioids is pushing those, and IV ketamine, of course. I'd kind of stick away from this category and focus on antidepressants, maybe gabapentin, pregabalin, and the topicals as sort of your first line options, and then move on from there. But there's not a ton of evidence for any of this stuff. It's sort of studied here and there in small studies. It's not like there's any like blockbuster major category of drugs that was designed specifically for neuropathic pain. They're all kind of secondhand, right? If you want to look at that, there's some other purpose to them, and they figured out that they work for neuropathic pain. All right, restless leg syndrome, kind of like an extension of neuropathic pain, an extension of, I think of it like almost like a mini Parkinson's disease with a neuropathic pain component. So overwhelming urge to move your legs. It's not just like people like me who really bounce their leg a lot when they sit. That's not restless legs, believe it or not. Even if somebody accuses you of having restless legs, I won't name anyone specifically. Significant leg movement during sleep, which can impair your daytime function potentially. Associated with an iron deficiency. Non-pharmacologic options, mental activity during downtime, regular exercise, reduce your caffeine, walking, cycling, massage, hot tubs. All that stuff can be shown to help and is probably more effective than drugs, just throwing it out there. If you want to use drugs, it's kind of like Parkinson's, but a really mini version. So dopamine agonists are heavily marketed for restless leg syndrome and are probably the standard, but they're much lower doses than you'd start somebody on for PD. Gabapentin, pregabalin. If the patient has impulsive tendencies, it might be good. Remember we talked about in the recorded lecture about how dopamine agonists can enhance some of those impulsive tendencies in patients. So these might prevent that potentially. And if a patient has underlying mental health disorders or anxiety, it might be a better option. There is this brand gabapentin extended release called Horizont, which you should never prescribe because it's ungodly expensive. Just stick with regular gabapentin. But it is marketed specifically for RLS. Carbidopa, levodopa, use very small doses. The only time I see this used is in, again, small doses and at bedtime is the common way that they'll do that for RLS. And it's pretty effective. So you see that done in older patients a lot who have RLS. Oftentimes it happens in the elderly years, and it's usually a lifelong illness. So people don't usually get better with it. Certainly the non-pharmacologic strategies are worth trying and enforcing, but you might not get anywhere with that. Yeah.
Are those used separately, or the one that's like together?
Which one?
Carbidopa.
Oh yeah, combined. So you never. That's a good clarifying point. You never use carbidopa, levodopa by themselves. They're always combined together. Sometimes there's other things added to them, like with the Stalevo brand, where you. But levodopa is what you'll read about. It's like the active drug, right? And carbidopa just alters how it's metabolized. So they're always combined together, and that's Cinemet. Yeah, if you gave somebody just levodopa, they'd get really nauseous really quickly, and it wouldn't really get to the site of action as efficiently. Bell's palsy. This is more for the people who want urgent care or EM. You'll see Bell's palsy come up quite a bit. It's pretty common. It's relatively, I would say benign, but it goes away. It's not like a super severe thing. You can get really severe presentations of it, but usually it's treatable. It's a sudden onset of unilateral facial paralysis, which makes people really concerned because they think they're having a stroke, or they think their person they're looking at is having a stroke. It's not a stroke. Outcomes are generally good, but again, the severity of clinical presentation. Usually people recover within 3 weeks of onset. A 7 to 15% chance of recurrence once you've had your first attack. Third to fourth attack, much lower. Pregnancy, family history are risk factors. No one really knows what causes it. There's a viral theory behind it, but the evidence is really poor that antivirals do anything for Bell's palsy. So one of the questions I used to get a lot was, and I feel like people don't ask me this anymore, so maybe they learned, but corticosteroids versus antivirals. There's one that has better evidence and one that doesn't. It's the steroids that have the better evidence. So if you're going to give somebody something for Bell's palsy, steroids should always be top of the chart, or top choice. And you usually want to begin within 3 days of symptom onset if you can. If it's past that, there's not as good of evidence that they do much. You could still prescribe them. And it's usually pretty high doses. So prednisone 60 to 80 milligrams a day for 7 days is a common first course for people. Antiviral, unimpressive evidence again. The only time they recommend this, I think, is that if you have a really high-grade presentation of Bell's palsy, valcyclovir is essentially benign. It doesn't really have a lot of side effects. So if you want to prescribe it, go for it. You might not get all that evidence out of it. But the point is that if you're going to prescribe valcyclovir, you should have the corticosteroid on too. So it's either corticosteroids alone or plus antiviral, but not antivirals alone. And then finally, narcolepsy. I promise this would be short, right? These drugs are actually kind of popular, and I don't know. They don't really fit in really well anywhere else. So narcolepsy, I've got one slide on it. Certainly you could try other things other than these two drugs. But Provigil and Nuvigil, modafinil and armodafinil, are basically the same thing. One's just an R enantiomer, as you can tell by the name. They're non-amphetamine wakefulness promoting agents. It's kind of an interesting name. People thought that these drugs were kind of like cocaine when they first came out because they actually made people feel like, people reported feeling kind of like they did. It was called legal cocaine as like a joke, I think, because people would abuse them for that purpose. It's kind of, I think of them like a stimulant. They have a lot of very similar effects to Adderall. They just don't work like Adderall. And so because they had similar effects, a lot of people thought that was the mechanism of action. Basically, like drugs like Adderall and Ritalin, which we'll talk about next module, they affect your neurotransmitters like dopamine and norepinephrine and serotonin. These drugs don't really do that. It's thought that they have some kind of a opposite effect on GABA. So the idea is with narcolepsy maybe is that you have an overexpression of those GABA receptors that are causing inhibitory responses, causing you to fall asleep at inopportune times. And so this is thought to kind of be like an opposite benzodiazepine maybe, where it blocks that process from happening. So benzodiazepines and some anti-epileptic drugs potentiate that and cause those inhibitory effects to happen more often and more thoroughly. This would actually work opposite of that. That's the theory behind what these do. They have some central alpha adrenergic activity, which might cause like a systemic sympathetic response type of a feeling as well, which might help with the stimulant type effects people feel it. But they aren't like a traditional stimulant, although I classify them very similarly. They're controlled substances, both of them. They're super abused. Peak effect 2 to 4 hours, duration is about 15 hours. Other than that, they're actually pretty well tolerated. People might get decreased appetite, headaches. CV effects are rare but possible. People might get some palpitations or chest pain. And then psychiatric effects, oftentimes probably going to be associated with an overexpression of sympathetic response and just overexcitatory activity happening because you're shutting down part of the brain's inhibitory pathways. So you're getting a little bit more of the other side of it. Now, if you dose it correctly, you shouldn't see too much of that, but it's still possible. So these are going to be some of the things you might see. And again, armodafinil, very similar thing. Lower reported percentage of side effects with that particular enantiomer, though, and I think it lasts a little bit longer as well. So, yes.
So would you use that over?
No, probably not. I think Provigil or modafinil is generic now, and armodafinil is a newer drug, so most people would probably be on Provigil, but I do see both occasionally come up. Yep. Okay, that's it. That was like 11 minutes. All right,